Okay, Assalamu alaikum everyone. I'm Dr. Sairah Sadaf, Associate Professor, Sheikh Zayed Medical College, Rahim Yar Khan, and today we're going to have our first session on ECG Made Easy. It's our day 1. I hope everyone can hear me. Bismillahirrahmanirrahim. Okay, the highlights of the lecture of today's session will be, we will briefly go through the graph paper, electrodes, ECG leads, wave formation, rate calculation, and cardiac rhythm identification. So starting from the very basics, so what is ECG? It's the abbreviation of electrocardiography. I hope everyone is familiar with that. And basically it's the recording of electrical activity of the cardiac muscle or the myocardium in the graphical form. Now this is a very typical tracing of ECG. All of you are familiar with. Now let's have a look on ECG graph paper. As we all know that the graph papers have x-axis and the y-axis, horizontal axis and the vertical axis. Now this one is the horizontal axis and this one here is the vertical axis. Now horizontal axis represents the time in seconds, while vertical axis represents voltage in millivolts, right? Now, as the graph paper is formed by different boxes, so let's zoom in one box. As you can see, this is a large square, and the large square has many tiny small squares in it. Each small square is 1 millimeter in height and width. Thus, 5 small squares will be equal to 5 millimeters. Now, on the horizontal axis, 1 small square is equal to 1 millimeter and 1 millimeter is equal to 0.04 seconds. Thus, 5 small squares will be equal to 0.20 seconds, or you can say 1 large square will be equal to 0.20 seconds. So it's easy. Okay, now on the vertical axis, 1 small square is equal to 1 mm and 1 millimeter or 1 small square is equal to 0.1 millivolt. Thus, 5 small squares will be equal to 0.5 millivolts, right? So just remember this. Now, significance of the duration. Why we're learning the duration? Because every waveform on the ECG have a different duration. And any increase or decrease in the duration means there is something wrong. And that we will learn later. Now coming to the ECG electrodes. ECG electrodes. So can anybody tell me that what is an ECG electrode? My online audience can answer in the chat box if they like to. जी आप लोगों में से कोई बताएगा? And I have my postgraduate residents in front of me in the class, so I'm also asking them. So these are the sensors. These are the physical hardware. These are sensors that are placed on the body surface area on the body, and these detect the electrical activity of the myocardium. More precisely, voltage at the skin level. Now there are different kinds of electrodes, limb electrodes and chest electrodes. Not kind of, these are 2 types of electrodes, limb and chest, and these are color coded. Now this is the this picture is showing the placement of the electrodes on the limbs and in the chest. Now starting from here, I hope you can see my cursor moving here. Yes? Yes, okay. Now on the limbs, we place 4 electrodes and the remaining 6 electrodes we place on the chest. So starting from here, right arm, left leg, right leg, and you can place the electrode from this to up till here, like anywhere in between this area. Same goes for here and same goes for here. From here, On the legs, you can place the electrode here, and you can go up till here, just below the torso. You can place electrode anywhere between in this area, right? And this one, my dear, this is the neutral one. We don't count it, but yes, we place it. But this doesn't count in the electrodes, not like a proper electrode that records anything. So it's a neutral one. Now coming to the chest electrodes, we start from the fourth intercostal space on the right side. Then the second one, the V2 electrode, the electrode that records V2 lead. We place it on the left side on the fourth intercostal space. Then V3 on the rib. Then V4 on the mid-clavicular line in the fifth intercostal space, mid-clavicular line. Here, mid-clavicular line, right? Then fifth one, again in the fifth intercostal space and in the interior axillary line. And the sixth one for V6, we place it here, again in the fifth intercostal space and where at the mid-axillary line, right? Now, the limb electrode placement has already been discussed, but just remember this mnemonic, read your green book. Read your green book is, now you have to, starting from here, you have to place a red one here, yellow one here, read your green book, all right? Now, there is another one that is by the AHA. So AHA has a different color coding. I have already told you about the Read Your Green Book, that is from the IEC, International Electrotechnical Commission. Now, the other one, the AHA is using American, that is a bit different. Use white, black, red, and green. So you can use the mnemonic, we bring red grapes. We bring, B for black, red, grapes, green, right? So this is the arrangement by the AHA. You can take a screenshot. Now the ECG leads. Now this is very interesting part. Now this is a very typical 12-lead ECG tracing. All of you are familiar with, and you have seen this many times. So these are the 12 lead, 1, 2, 3, AVR, AVL, AVF, and on this side, V1, 2, 3, 4, 5, and 6. And sometimes there is a rhythm strip at the end. What is a rhythm strip? Yes? Lead 2 and for 6 seconds. We take a rhythm strip of lead 2 for 6 seconds. We record it for 6 seconds. That is known as a rhythm strip. So anyways, these are known as the limb leads, and these are known as the chest leads. From lead 1, 2, 3, AVR, AVL, AVF, these are limb leads. While starting from V1 to V6, these are chest leads, or you can also call them precordial leads. Now, this is another simplified view. Limb leads all on this side, and chest leads all on this side. Now, there's another subcategory of the leads. First of all, there is unipolar and then there is bipolar. Talking about the unipolar, the precordial leads from V1 to V6 will always be unipolar. And then AVR, AVL, AVF, these will also be unipolar. Now about the bipolar, only lead 1, lead 2, and lead 3, these are known as bipolar. For future reference. Bipolar, these require 2 poles or 2 physical electrodes, positive and negative, as the name indicates. And the unipolar, they require 1 physical electrode, or you can say pole, and second pole is invisible. ECG machine does all the math and creates a center point for the comparison, right? So there's no need to go into further detail. Okay, now what are the leads? What is a lead? The simple version or simple definition. And then we will go to a more difficult one. Now, usually people mix up the leads and electrodes. Now, first of all, electrode, as I have already mentioned, is a sensor that placed on the chest or arm and it detects or senses the cardiac electrical activity on the scale, right? Now, what is a lead? Lead is basically ECG tracings on the graph paper. They're appearing as positive and negative deflections, positive, negative, up and down, upstroke and downstrokes. And they basically show the differences of voltages produced by the myocardium. And basically, this is an electric view of the cardiac activity, right? I hope all this is making sense to you. Now, why leads are different from each other? This is a very interesting question. Although the electrical activity is the same across the myocardium, right? But we still get ups and downs in the ECG, like upward stroke, downward stroke. So why is that? So for that, let's understand this with a very self-explanatory analogy, and I will show you just in my next slide. So now this is a bit a deeper concept. First of all, let me define it, and I will try to simplify it as much as possible. Leads are basically different viewpoints of the cardiac electrical activity at different angles. It simply means that you are looking at the electrical activity of the heart from different angles. I hope it's making sense. Now, let's have a look on this self-explanatory analogy. As we all know that the SA node, it starts or initiates the electrical activity. Depolarization starts here, right? And then it goes and spreads all around or across the myocardium. Like this. From here, it starts from here, and then it spreads across the myocardium. Now, these are the electrodes placed here. As you can see, the smaller ones here. See? Now just think of the electrodes as cameras placed at the different angles. As the cameras are placed at the different angles to detect the cardiac electrical activity, so obviously each one of the camera will have a different image of the electrical activity, right? That is why at the end, we will have different images from different cameras. And that's why leads are different from each other. Now, I will explain this with another a beautiful analogy. Let's take this runway analogy. Now, take this runway as heart. This runway, this is heart, myocardium, and this model walking down the runway, she's electrical activity, or you can say the electrical impulse. She's the same. She will not change. She's same. The people sitting here and people sitting here, and the people sitting on the front and people sitting on the back side, everyone will have a different image of her. The people sitting here will have her front view, and the people sitting on the back will have her back view. So obviously, at the end, everyone will have a different image of her. So that's why leads are different from each other. Although electrical activity is the same in the heart, right? So I hope all of you understood this. My PGRs, yeah? Okay. And my audience on the internet, my online audience, I hope all this is making sense. This one is very important. ECG leads represent which side of the heart. You have to memorize it, right? This thing is very important because this will keep coming in again and again. So during our session, so you have to memorize it. Now, each lead represent a different side of the heart. So it's not like echocardiography, it's electrocardiography. Each lead represents a different side of heart, means different side, the electrical activity going on in the different side of the heart, right? So each lead represents electrical activity in the different side of the heart. Just a second, please. You can take the screenshot of this. And now the lead 2, 3, and AVF. These are the inferior leads because they represent or reflect the electrical activity in the inferior side of the heart or the inferior of the heart. 1, AVL, V5 and V6 are the lateral leads. V3, V4 are the anterior leads. V1, V2 are the septal leads. Now, what is this? Limb leads give you longitudinal viewpoint of the heart. They are looking at the heart from the sides. Like a simplified view of it. A simplified version of it is to just make you understand. The limb leads basically are looking at the heart or reflecting the heart. More precisely, they are reflecting the heart or the electrical activity of the heart from the sides, not from the front, like chest leads. So that is the difference between chest leads and limb leads, that limb leads are looking at the electrical activity or they are reflecting the electrical activity of the heart from the sides. Okay. Now the AVL, AVF, AVR, these are unipolar leads, as we have already discussed. These appear on ECG paper and they're being recorded by their respective electrodes. What is that? As you can recall, you place the right electrode here and another electrode on the left arm and another electrode on the left leg. Yes. So AVR is recorded by the electrode placed on the right side. So it is looking at the electrical activity of the heart from the right side. AVL is recorded by the electrode placed on the left side. AVL, L for left, R for right. AVF is recorded by the electrode that is placed on the foot. F for foot, inferior foot. So I think this is very easy to remember or memorize. Now, lead 1, 2, and 3, these are bipolar. These are recorded between the two electrodes. Like when the electrical impulse is moving from right to left, so it is recorded here. So when it goes down here, it is recorded here. And when the electrical impulse is going down here inferiorly, it is recorded here. So lead 1, 2, and 3 are generated. Now, it is a very important concept to remember, the axis of the heart. Axis of the heart is infralateral. Axis of the heart is infralateral. What is that? As you can see in this picture, more towards the lateral, and it inclines inferiorly. So it's like this. My PGers can see me. It's like this. It's not like this. It's like this. All right. So anyways, so does the direction of the electrical activity. Like jahan dil hoga usi tarah jayegi na. So the direction of the electrical activity or the electrical impulse is the same as the axis of the heart. Of course, obviously. So now a very important concept to remember. When the electrode perceives that the electrical impulse is moving away from it, it will have a negative deflection. And when the electrode perceives that the electrical activity is moving towards it, it will have a positive deflection. Right? Like this. And a negative deflection like this. We call it positive deflection and negative. Why? Why we call it positive? It's upward, I know that. But why we call it positive? Because it's on a graph paper. On the graph paper, there are always negative and positive ends from the baseline. If anyone can recall from your maths, from your metric or FSC, right? So on the graph paper, there is a baseline. And from the baseline, the things going up or down are known as the positive or negative. Okay. All right. So anyway, so this is so again, in the AVL leads is always positive. Why? Because it is recorded by the electrode placed on the left side, which detects the electrical activity moving towards it. Why? Because of the axis of the heart. What is the axis of the heart? It's left lateral. It's left, inferior, and left. Just remember that. Inferior and left. So the AVR is always upright. And if it is downwards, it means there is something wrong. Now about the AVR, it will usually, most of the time, always it's negative. Why? Because it is recorded by the electrode on the right side. So it detects that the electrical activity is going away from it. So of course, it will give you a negative deflection in the lead AVR. Now about the chest electrodes, precordial leads. Now the electrical activity is coming from inside to outside, of course, towards them, and they are just on the chest. Now, very interestingly, you can see V1 and V2 are almost on the right side of the heart, and V5 and V6 are almost on the left side of the heart, right? So V1 and V2 represents the right side, right heart, and V5 and V6 will represent left heart. Just try to memorize it because this will be on repetition in our session. And what else? Oh yes, and V1 and V2 as these are on the right side. So, and electrical activity is moving on as along the axis of the heart, that is infralateral. So these two electrodes perceive that the electrical activity is going away from it. So there will be a negative deflection in the V1, V2 lead. While V5, V6, these are exactly in the cardiac axis. They are sharing the same axis as the heart. They are on the left side. See? So they will perceive or they will detect that the electrical activity is moving towards them. So there will be a positive deflection in V5 and V6. Now just remember that why we have to remember this or memorize this, that why we have positive negative deflection in right lead or left leads or lateral leads. Why? Because when these normal findings become reversed, if you have a positive deflection in lead V1 and V2, it means there is something going wrong in the heart. So that is why it is important to memorize that in which lead you will have upright QRS complex and in which lead you will have a downward QRS complex. All right. I hope everything is making sense to my online audience. Now, this is the P wave. As you can see, this is the PR segment. And from here to here is the PR interval, as you can see here below. This is the famous QRS complex. And this one over here, this small segment is ST segment, the notorious one. This is the T wave, and sometimes we may have a U wave and sometimes we don't have. And QT interval starts from here, from Q wave to the end of the T wave, QT interval, the famous QT interval, right? Okay, now the normal conduction pathway of the heart. Now, as we all know that the electrical impulse starts from the SA node. It goes to the atrial muscle. Atrial muscle depolarize, or you can say contract. It goes to AV node. Just a bit of a lapse there, or you can say just a bit of waiting period there, and then it goes to the bundle of His, left and right, and divides and spread all across the ventricular muscles, and then ventricles contract. End of cardiac cycle. Now, this is a very interesting part on ECG. And I literally love this concept. Like, you can just tell easily by just looking on the ECG that atria is contracting properly or not, and ventricles are contracting properly or not. How? Because ECG has two parts. Now, as you can see, very self-explanatory picture here. Up till here, this is the part that represents contraction of atria. And after this, it shows the contraction of ventricles. So any pathology lying here, a D-shaped P wave or any distortion in P wave, any prolonged or shortening of the PR interval, showing that there is something wrong with the atria, not with the ventricle, right? And any pathology afterwards, after this part, will be related to ventricles, ventricle pathology, whatsoever pathology, right? Now, how the waves are generated. This is very beautiful. I'm sorry for the blurring of the slide, but this is a very beautiful slide, a very self-explanatory, but let me explain it for you. Now the atrial depolarization, it generates P wave. P wave will always tell you the atria is contracting. If there is no P wave, that means atria is not contracting. It is either fibrillating or fluttering. How beautiful is that? Now, what is this? PR segment is the, as I have told you, the delay at the AV node. Now, the ventricular depolarization, as I have already told, when there is a QRS complex, a proper, beautiful, smart, slim QRS complex, you can tell that ventricles are contracting properly, are being depolarized like properly. But if there is any slurring, increase in the duration, or any notching, any bizarre appearance of the QRS complex, so you can identify like immediately that there is something wrong with the ventricles. Now, ventricular repolarization. The T wave shows the ventricles have started repolarizing. The action potential system has been at the stop, and the next cycle will start afterwards. And this single straight line, we call it isoelectric line. It shows that for the just short period of time, there is no electrical activity in the heart. Now, this is very interesting. Like there is some time then there is no electrical activity in the heart. Okay. Take a break. Just 1 minute break and I will come back. Start again. Now, we will discuss different waves, each wave at a time. Just a brief, not very much details, because details are coming later in my second and third session. Don't miss those sessions. Now, as I have already mentioned that the P wave represents that atrias are contracting. So when there's atrial contraction, there will be a P wave. Now, what do you have to look for when you are looking at P wave in ECG? Look for its shape, look for its duration, and look for its position. Look for its position. Why? It has to come before the QRS complex. And there should be a PR interval between them, a PR segment between them. And if it's coming like haphazardly, anywhere between the complexes means QRS complexes, then there is something wrong. That means there is something atrial arrhythmia is going on. All right. Now, it may be absent when there will be atrial tachyarrhythmias, atrial flutter, atrial fibrillation, and supraventricular tachycardias, as I have already mentioned. It can be inverted when maybe due to the wrong placements of electrodes, dextrocardia, or AV junctional rhythm. I'm sorry for the spelling mistake. Now, it can be tall and it can be wide. Now, this is very important. It can be tall. That means it will be more than 2.5 millimeters or more than 2.5 small squares. And wide means it will be more than 2 small squares or 2 mm, right? Now, these are the different abnormal shapes of the people. This is not a very good slide. So I have another slide. But anyways, so the normal shape of P wave is a rounded tip. Its width will be about 2 mm and height will be about 2 mm or 2.5 mm. This is not a very good picture. Let's ignore this. Now, P pulmonale means when the P wave has more height, more than 2.5 mm or more than 2.5 small squares, you can say. And this is the P mitral. It is a broader P wave that is more than 2 mm of more than 2 mm or more than 2 small squares. And it's usually have a notch here, as you can see. As you can see here, right? So this is P mitral. I have another, like a very beautiful picture of it. Now this is a very good one here. As you can see, okay. Now this is a tall P wave. This is another tall P wave. This is known as, it is called as P pulmonale. This, as you can see, this is a tall P wave. It is more than 2.5 small squares. We call it P pulmonale. What, as the name indicates, P pulmonale. Can anyone tell me what it will tell you? Pulmonary pathology. Very good. All right. Now this is P mitral. Now, can anyone tell me what does that mean? P mitral? Mitral valve, or no, with the heart, cardiac problem, left side of the heart. So anyways, this is the P mitral. As you can see, this is broader, more than 2 mm, 2 small squares. And in the lead 2, it appears like this. But in the lead V1, it appears like this. In the 2 phases, it has 2 components. The right component shows the right atria, left component shows the left atria. How beautiful is that? Now let me show you another slide. This one is very beautiful slide. You can take a screenshot of it. Now this, we have 2 leads, lead 2 and lead V1. We have to look for P wave in 2 leads, lead 2 and lead V1. Now what do you see in lead normally? Normally, what do you see in the P wave? When you are looking at P wave in lead 2, normally it appears like this. Single, rounded, small, less than 2 mm, wide or tall. And in lead V1, it may appear like this, where both the waves are normal. Both the components are of same size, you can say, same length, same size. Now, in case of P pulmonale, you will have a tall P wave in lead 2. And just pay attention to this one. And in lead V1, what do you have here? You will have a taller or bigger component of the right side than the left side. That will be indicating that there is some pathology with the right atrium. How beautiful is that? Hannah? I love this concept. And in case of P mitral, it will be broader in lead V2 with a notch here, showing 2 components, right heart, left, right atrium and left atrium. And in lead V1, you will have a more bigger left component than the right one. It will be more broader. As you can see the difference here. See, like in this slide, in the P pulmonale, when there was a problem with the right atrium, you can appreciate that the right component is bigger than the left component. And when there was left atrial pathology, left component was bigger than the right atrial side of that. See, right? Understood? What's this slide? This is PR interval. Okay, about the PR interval. Now, the total duration. Now, what PR interval actually represents? As I have already mentioned, PR interval represents the total duration of atrial electrical activity. Normally, it's between 3 to 5 mm. And if you want to mention it or want to memorize it, in the time duration, it's 0.1 to 0.2 seconds. It may be prolonged, but not maybe. It's always prolonged, usually prolonged in AV blocks, and sometimes it's shorter in these conditions when it is bypassing AV node through abnormal accessory pathways. Depolarization occurs at the AV nodes, moving towards SA node and ventricles simultaneously. May be seen in WPW syndrome or LGL syndrome. The abbreviations are here on the bottom of the screen. You can see this. Now, this is a normal PR interval. This is not a very rocket science here. It's a very simple slide. PR interval starts from here, ends here, and as you can see, this is prolonged because it's more than 3 to 5 small squares. So this is a prolonged PR interval, as you can see, and this is very obvious. This is another slide showing the prolonged PR interval. Now Q wave. A Q wave is significant, but when it is significant. This is important. Not every Q wave is significant. You have to remember when which kind of Q wave, at which kind of Q waves you have to be alert. So if it is present, it may be normal. It's normal due to septal depolarization between the two ventricles. You can have a Q wave. So it's normal. But important is when it is significant, when you have to start worrying about its presence. When it is wide, more than one small square, or it is deeper, more than two small squares, or it is 1/3 of the height of the R wave. It is present in myocardial infarction, LVH, and bundle branch block. And in lead 3, when it is present, it shows pulmonary embolism. Not always, but it may represent pulmonary embolism. In myocardial infarction, why Q wave is there usually? It's just for your a little information, FYI. So when no current flows through the necrosed area, Q wave is produced. Now this Q wave is present, but it is not significant. But this one here is very much significant. See, deeper, broader, and height is more than 1/3 of the R wave, even very much more than the R wave. Again here, this is the very, very significant Q wave, deeper, broader, and as I have told you, more than 1/3 of the height of the R wave. R wave to nazar hi nahi aa rahi. Now about the QRS complex, important part. So first of all, tell me what QRS complex represents, Amna? What? Ventricular depolarization. Yes, atrial artery. Achha. So its duration should be less between 2 to 3 mm or 0.12 seconds. Shape, everybody knows how it looks, but I will show you again. If it is too tall, it means there may be hypertrophy. We will go on all the criteria of hypertrophy, LBBs later in my slides. So today we are just having the basics of it. Now, too tall means hypertrophy, R or S wave more than 25 mm. This is older criteria. Now I have a newer one for you. Just forget this. Now, if it is too small, pericardial. If it is too wide, bundle branch block or different kind of arrhythmias. It is too narrow, incomplete bundle branch block or WPW syndrome. Now, these are the different kind of Q waves you can see along with the RS pattern. We will discuss it later in detail, but let me show you few things about it. These are different kind of presentations of Q wave with the R and S waves. And this is very important to learn it now because tomorrow we have the session on LBB and hypertrophy and all those things. So these will appear there and these will come again and again in those slides. So you have to understand it now so that I won't waste my time tomorrow again on these slides. So when we write small rs, it means that we have a small r and small s. Okay. When we write small q with tall, big R, capital R, and small s, it means that exactly literally we have a small Q wave, a giant tall R wave, and again a small S wave. That's why we write it small s with a capital R. Now, when we write it like this is small r, this is small s, and then again another R with a dot on it. We call it R prime. We call it R prime, P-R-I-M-E, R prime with a dot on it. It indicates there is something gross pathology going on inside the conduction pathway. And we have another R wave, which means that the cardiac impulse is not going into the ventricles properly. It's going back somewhere else. When there is two R waves, it means there is a gross conduction pathology and the impulse is not going through its normal conduction pathway, SA node to AV node to Purkinje's and all that. It's going somewhere else. It's not going there, going downwards and to the Purkinje cells. And it's spreading haphazardly and back to its center. So we will have another R. So that's why we put a dot on it. It is R prime. And so we will have an ECG like this, a small R wave without a Q. See, there's no Q wave. Q wave is always downward. So we will have an R wave, a small S wave, and then again a giant R wave. And because it is a second R wave, we will have a dot on it, the R prime. Now, this is RS pattern, small r, a capital S. What is this? You will have a small R wave with a deep S wave, big S wave. So that's why we have written it as like, literally we have written it like R, small r with big S, capital S. Now this is QS pattern. This is usually we see this pattern in myocardial infarction, old ischemic changes. It represents old ischemia. Now, the QRS complex, about the QRS complex, as I have mentioned, it may be broader, more than 3 small squares. It's not a normal QRS complex. Again, you can see in this ECG, it is broader, more than 2 to 3 small squares. It is too much broader. And its shape, so is it a normal shape QRS complex? No, it's not a normal shape QRS complex. So it is an abnormal QRS complex. We will discuss it tomorrow that what it is. What is this? Today, we are just talking about the normal and abnormal looks, morphology of the all the waves, one by one. So this is a broader QRS complex. Now about the ST segment. It shows the early part of the ventricular repolarization. It is isoelectric means. It will be flat. It's not a wave. It's just a segment, right? It will be flat. But if it appears like a wave, then it means there is some pathology. If it goes up, if it goes down, if it appears like this, if it appears like this, it means that then there is some pathology, and now you have to start worrying about it. So until ST segment is flat, we call it isoelectric. So it may be elevated in STEMI. STEMI is ST segment elevation, MI, Prince metal angina, pericarditis, aortic dissection. There are so many other conditions, but I have just mentioned a few more common conditions. When it is depressed, nowadays everyone is depressed. So ST segment may be depressed when there is non-STEMI, maybe due to different drugs, antiarrhythmics, and maybe due to electrolyte imbalances. Now, this is a normal shape of ST segment. Interestingly, we compare it, the baseline is PR segment. We take PR segment as baseline, and we compare its elevation or depression when we compare it with the baseline of the PR segment. So this is the baseline. PR segment is here. Now, when we will say it is elevated, when it is elevated from the baseline. So what was the baseline? PR segment. And when we call it is depressed, when it is below the baseline. What is the baseline? PR segment. Now, what is the J point? J point is the point where basically the QRS complex ends and the ST segment begins. This is J point, like over here, as you can see. Right? About the T wave. T wave shows a late or complete repolarization. ST segment was early repolarization, and T wave is the complete repolarization or late repolarization. So it's about 2 to 3 small squares. Its shape, usually it's a rounded shape normally, and it's upward always, but it may be inverted. Why? When it may be normally inverted in the lead AVR, lead 3, and in young people in lead V2. There's maybe pathological inversion. When we will say it's pathological inversion, when there is ischemia, hypertension, LVH, and electrolyte imbalances. It may be too tall. In acute MI or hyperkalemia, it may be too small. in hypokalemia, effusions, or hypothyroid. And there are so many other conditions as well, but I have mentioned here the very commonest ones. Now, these are different shapes of the ECG of the T wave. Usually it is normally rounded from the top. It may be biphasic. Kiran, this is biphasic. Although it's a T wave, but it's biphasic. It's not deflection. Okay? Whenever we use the term deflection, we use it for the QRS complex. Right? Okay. So P wave may be biphasic. T wave may be biphasic. T wave may be notched. It may be broader. It may be totally flat due to any pathology. This is not, and all these are not normal. These are the abnormalities. It may be tall. It may be downwards. When it is downwards, maybe ischemia. It may be inverted in the strain during strain on the heart due to any reason. I will tell you later. And it may be flattened like this due to the prolonged QT interval. Now, this is a very beautiful thing I'm going to explain to you. Let me use my pen here. Okay. So, we all know that when we say that T wave is inverted, it looks like this. It's a T wave inversion. It has, as you can see, this is the T wave. It is inverted, right? This T wave is also inverted. But there's some difference if you look closely on the two T waves. This one over here looks like simple T wave inversion, just like this. Sorry for my drawing, but it's a simple T wave inversion. Rounded, no, like almost rounded. Or you can say both sides look same. Both sides of the T wave look same. But this T wave inversion is different. This is called as strain pattern. In this, it is asymmetrical T wave inversion. How come? Both the sides are not same. One is little slopey and the other one is like this. Can you see? One is slopey and the other one is like this, rounded. In this, both will be rounded. In ischemic T wave inversion, T wave will be rounded on both sides. The both sides of the T wave will be rounded. But in strain pattern, when we say it's a strain pattern, we will have an asymmetrical T wave inversion. Asymmetrical means both the sides of the T wave will not be same. One will be like this, the other will be like rounded. It is different from this, as you can see. I cannot draw any better than this. QT interval. As the PRA interval was showing the total activity of the atria, QT interval shows the total activity of the ventricles. Like activity means electrical activity. Now, when it is too long, more than 0.3 seconds, 4-3 seconds, hypocalcemia drugs, or it may be inherited as well. It may be too short, less than 0.35 seconds, due to hypercalcemia, digoxin, or so many other things, but these are the commonest ones. Now, progression of waves pattern, very interesting thing. We will take one wave at a time and we will discuss why it look like this. The deflection part. Now, progression of waves in different leads. We will have positive deflection. Then we will have a negative deflection, although it is already discussed, but I will repeat it again. Progression of R wave and regression of S wave. This is a very important concept to build. And then isoelectric waves. What are isoelectric waves? Now, before starting this, I want to tell you that the chest leads on the ECG, from them, so among the chest leads, the V1 and V2 represents the right side of the heart, as we have already discussed in the previous slide. While V5, V6 represent the left side of the heart. Just keep that in mind. Don't forget this. And positive deflection will be when the electrical activity or the electrical impulse is moving towards the electrode. And we will have a negative deflection when the electrical activity is moving away from the electrode. So now, okay, I will we will discuss one wave at a time. This is very interesting part. And I love this part actually. I love every part of the ECG. So anyways. So now, first of all, अब मुझे कौन बताएगा? Who will tell me that lead 1 represents which side of the heart? Remember, I have already showed you that slide. And I have asked you to memorize it. Have you memorized it yet? G, कौन बताएगा? Left, very good. So, as the lead 1 reflects the electrical activity on the left side of the heart, so it means that it should always be positive. Very good. Lead 2. Lead 2 reflects which side of the heart? Left. Yes. Okay. Left and inferior. Very good. Very good. Very well done, Amna. Left and inferior. Very good. Infralateral. So it is the exact of the axis of the heart. So it will always be positive. It will always be upward. Now which one is this? Actually मेरा ऊपर ही आ रहा है मुझे. हाँ, आपको तो नजर आ रहा है कि मुझे वो नजर नहीं आ रहा. Lead 3. Lead 3 again is inferior. Yes, good. Inferior. So it will have QRS complex usually upwards. Now AVR. Who will tell me? Just a second. मैं chat check कर लूँ क्या कह रहे हैं. Anyways, AVR. About AVR. So AVR is on the. It tells you about the activity going on the. So how QRS complex will appear here? Negative. Why? Because electrode that is recording AVR detects that electrical activity is going away from it. Of course, because electrode is placed on the right side and electrical activity is going on the infralaterally, away from it. Now AVL, L, left. So left we will have a positive deflection. Don't look at this ECG. This is not actual. So we will always have a positive deflection, upward QRS complex. And again, AVF, F, foot inferior. Inferior means positive deflection. So understand, I hope everyone understood this. Now about the, yes, that is just for the reinforcement, this one. Just to tell you again that where the electrodes are placed and all that. Now about the precordial leads. Let me see the chat box. Negative because actually going opposite. Yes, Sahid, you're right. Okay, now about this one. Now tell me, V1 and V2 represent which side of the heart? Right side. Very good. So we will have a negative deflection on ECG tracings in lead V1 and V2. Always remember that. But if there is a positive deflection in V1 and V2, that means there is something wrong on the right side of the heart or anywhere in the heart. Just remember that. Okay. Now, V5, V6, these are on the left side. They show the electrical activity going on the left side of the heart. So they will always be positive. But if there is anything wrong or there is a deeper S wave means negative deflection. Yeah, or you can say predominantly negative deflection in V5, V6. That means there is something wrong. Okay, now about the rate. How to calculate the heart rate? It's very simple. Now the practical things on the ECG, from ECG. First of all, you have to mark R wave. Now, as you can see, these are the two R waves. You have to take any two R waves. Try to take the R wave that is coinciding with the dark line. So it will make it easier to count the boxes. Now, what you have to do is you have to count the large squares between these two R waves and divide it on 300. 300 is the rule of thumb. Just remember this. Memorize it. 300. Although there is a science behind it, I can tell you, but it will just a waste of time. So just go to the practical things. Now you have to count. There are 4 boxes, as you can see, because half one is here and half one is here, so it makes a 1 box. So there are 4 boxes divided on the 300. 300 by 4 will give you 75. The heart rate is 75. Now on this slide, these are 2 R waves, and you can count the boxes 1, 2, 3, 4, 5. Divide it over 300, and you will get 60. The heart rate is 60. Now, what if the rhythm is not normal? In those slides, the rhythm was normal. How do we identify when the rhythm is not normal? This is my next slide, actually. So when the rhythm is not normal, what you do? You take a 6 seconds rhythm strip. And see, this is a 6-second rhythm strip of lead 2. 1, 2, 3, 4, 5, 6. There are 6 Pierce complexes in this. You will multiply it with 10 and you will get answer 60. So the heart rate is 60 per minute. Now, can you tell me what is the heart rate here? Now, my online audience and my PG are sitting here. Kindly calculate the heart rate and tell me. And the next 2 are our last slide for today. $33. आपका क्या आंसर है? My online audience, kindly calculate the heart rate and tell me what is answer. Okay. जी ताहिर, आपका क्या आंसर निकला है? हाँ जी, आयशा खान is saying 30, 33, 30, okay. जी, 30, Amara, 30, Amara Sadaf. So Dr. Amara is also here. How are you, Amara? It's just good to have you. 30, 30. People are saying around 30 and 30. All right. So it's a bradycardia. Okay, good to have you. Thank you. Thank you for joining. Yes, Jennifer, 33. Good. Okay, so heart rate is 33. So this ECG shows that patient is having bradycardia and 33 heart rate. बैठे क्या कर रहे हैं? Resuscitate कर रहे हैं. Okay, चलें. Next, what is the heart rate? जल्दी जल्दी हमारे पास टाइम थोड़ा रह गया. It's very easy. इसमें थोड़ी सी गड़बड़ है. चलिए अच्छा कर लो. Okay, Bilal saying 78, Pradeep saying 60. हाँ जी, क्या आंसर है आप लोगों का बीजीज? 75, 85. ये 3.5 स्मॉल लार्ज स्क्वायर्स हैं, पूरा नहीं है. ये देखें यहाँ पे, ये वाला. Just look here, see this one. Half, 1, 2, 3, 3.5. These are 3.5 large squares. You have to divide it on 300 and you will get 85. So 85 heart rate. This is a normal ECG. Okay, next one. G, इसका बताएं. $150. जी ताहिर, आप बताएं. 150. Okay, let's see what they're saying. Ahmed saying 150. Okay. Aisha Khan 150. Iqbal 50. Dr. Iqbal, ये अपने डॉक्टर इकबाल हैं जी. डॉक्टर इकबाल 150 or 150. 150. Yes, great. Everyone is doing good. Excellent. So this is 150. Looks like this is 150. Yes. Now what is the heart rate here? This is a tricky one. Just be careful. Irregular 110, 96 to 100. Okay. Let me tell you, it is actually 110. So Amna was right. There is prominently 11 QRS complexes. Multiply it with 10, so we will get 110 beats per minute. Or you can memorize it. Ratta maar le. Now the last is the rhythm. It's the last slide, second last slide. Now what you have to do, how you tell the rhythm is normal or what? Count the small squares between 2 consecutive R waves. Or you can also count the large square between the consecutive R waves. Or you can also do the dot matching. What is dot matching? I have to draw it for you here. Like, let's say, okay, no, I have another one. Oh, yes. Okay. I will tell you what is dot matching. So as you can see, the number of large squares, or if you help yourself counting the small squares, you can count it. So just count the squares between the two arrays, and you will see these are equal between the all the arrays. It shows that the rhythm is normal. But down on the bottom in this ECG, first of all, it's very obvious that the arrays are not coming on the regular interval, RR. We call it RR interval. How do we know that? Because these are, the R waves are at not equal distances. The other method, as I have told you, the dot matching, is that what you do is you take a piece of paper, you mark one R wave here, mark other R wave here, and then keep on rotating this paper all across the ECG. You can match this, keep on moving the paper on the ECG, and you can match these dots with all the R waves. So of course, so you will get the whole picture that the R waves are not coming on the equal intervals. Now that's all for today. So thank you everyone for joining today.